Good evening, everyone. Welcome to Australian New Zealand Head and Neck Cancer Society webinar for tonight. We are very pleased to have Suzanne Chambers presenting today. I'm just going to hand over straight to Suzanne after a quick little introduction to us. So I want to start this meeting by Tracy will join us in a minute. We're just having some technical difficulties. I just want to start this meeting by acknowledging the traditional owners of the land on which we gather today and the many lands on which we undertake our work. We recognise their continuing connection to these lands, water and culture, and pay our respects to their elders, past, present and emerging. We want to point out some housekeeping rules. There is a Q&A button down the bottom where you can click and to ask any questions that will come up for us to be able to pop those up for Suzanne as we go along. Feel free to pop questions in at any point in time, and Tracy and I will be able to moderate that. And we do want to encourage anyone who isn't a member to become a member, so you can have access to wonderful webinars like this, as well as discount attendance to our annual scientific meeting, which is happening in Melbourne this year at the end of August, 29th to the 31st of August. So we'd really love to see you there. And we also, some of you may know, have a research foundation which provides grants to research in the area of head and neck cancer. And it's a really wonderful organisation to contribute to, and all donations are tax deductible. So just with that, I'm going to hand over to Suzanne for her very interesting presentation for tonight.
Lovely.
Thanks, Suzanne.
Okay, thanks so much. And thanks those of you who have come to listen to me speak tonight. And I know it's almost the witching hour, isn't it? It's time for dinner and you've all had a busy day at work. I'll just tell you a little bit about me so that you understand the perspective that I'm coming from, and then I'll pop my slides on. So I'm a registered nurse and I'm also a health psychologist. I've worked as a practitioner, researcher for goodness me, certainly more than a decade now. And before that, I was working in community-based cancer support for more than 20 years. And before that, I was a nurse on the ward. So I come to the issue of psychological support for cancer patients from a very practical point of view. Based on my practice, and I still practice. Although I'm in an academic position, I'm just going to get my slides up while we're chatting. I still run a psycho-oncology clinic one morning a week, which is really important to me because it is work that I love. And it also means that when I'm talking to you from the perspective of current experience. Now, we've just been having a few technical problems here, and there we go. Sorry, everyone, I'm self-talking myself through this. So what we're here to talk about tonight is psychological distress in oncology care and the sixth vital sign. And I'll talk to you about what that means really as we go along. But certainly, I'm sure this is a topic that's common to often in the thoughts of many of you as you work with these very vulnerable cancer patients every day of your working week. Now we've lost the slides. Let's have another go. There we go. So I'm going to start this talk with a quote that was the favourite quote of a woman called Professor Jemmy Holland, who was from Memorial Sloan Kettering. She was the founder of the discipline of psycho-oncology. I'm a psycho-oncologist. Psycho-oncology is the subspecialty of considerations of the behavioural aspects of cancer care. And this discipline really got going in the late 1980s, early 1990s. And Jimmy Holland, who died in December 2017 and is sadly missed by all of us, she was a psychiatrist, and she was the person that really brought this to the fore and in fact made Memorial Sloan Kettering Cancer Center in New York, really the global center of psycho-oncology. This quote was from Francis Peabody, from actually a seminar he gave at Harvard Medical School way back in 1926, and it was published in JAMA in 1927. And if you read it, it's the good physician knows his patients through and through, and this knowledge is dearly bought. Time and understanding must be lavishly dispensed, but the reward is to be found in the personal bond which forms from the satisfaction of the practice of medicine. And the last part of this, the secret and the care of the patient is in caring for the patient, was Jimmy Holland's favourite quote. And I think she really exemplified what draws us to cancer care, what we're looking in and what we need to focus on, the basics of understanding the patient and caring for the patient in order to ensure that we are giving full holistic cancer care to that person. So conceptually, the framework that I think is most useful in thinking about the cancer experience is to think of it as a major life stress. And this conceptualization really came about in the 80s and the 90s. And my experience is that cancer patients really understand this when you're explaining to them why they might be suddenly, they've got this news, they're in shock and they're finding themselves feeling really distressed. And that can be a really confusing and disorienting experience. If you think about cancer as a major life stress, it's a threat to survival. The first thing that people will wonder is this going to kill me? Reasonable thought and concern to have. It's a threat to the sense of self. Am I going to be the same person after this? How will my body change? How will my relationships change? And how will my lifestyle change? And so all these things at one point or another in the cancer journey will be of concern to your patients. And these concerns will change over time depending upon the point in the illness experience that they are situated. Now, there have been lots of descriptive studies since this discipline started to tell us that there are a substantive subgroup of patients who experience clinically high psychological distress after a diagnosis of cancer. If you look more generally overall, you would say it's probably about 25 to 30% of patients at some point will be really clinically anxious or depressed or have an adjustment disorder. But of course, that varies across cancer types. And when you come to certain cancers, specifically things like lung cancer, pancreatic cancer, and head and neck cancer, these patients actually report a higher prevalence of distress. So being concerned with the psychological distress of your patients should be really high on your agenda. There is an increased risk of suicide in cancer patients compared to their non-cancer peers. And this is especially for prostate, lung, pancreatic, and head and neck cancer. So the consequences of us not paying attention to the psychological well-being of our patients is really very serious. And in fact, some people will take their lives. The types of expressions of psychological distress can be anxiety and depression is not uncommon. Post-traumatic stress, particularly if a person has had a very traumatic treatment with a very high burden of that treatment. A fear of cancer recurrence that can go on, can be lifelong. It can certainly go on for many years. Suicidal ideation is not uncommon. For certain cancers, stigma and shame, and I'll be talking about that a little more tonight. A negative self-image and disgust, again, relevant for head and neck cancer patients, a loss of identity along with that, and certainly a strong sense of grief for many people that this has come to pass. Relationship and or family conflict can occur as well. And of course, for the family and the carers of the person with cancer, there can be a very substantial caregiver burden that can actually compromise the health of the person who is closest to the person with cancer. And again, this will be more for some cancer types where there's a heavy treatment burden. And then when the requirements of that mean that the caregiver has a very high caregiver burden. Now, for many patients, this distress will resolve as they move through treatment and they will get back to a changed life. but a life that approximates the level of well-being that they had before. But for some patients, this distress will really persist into the long term. And of course, there'll be critical incidents when that distress may heighten and recur, and things like a point of recurrence, emergence of a new side effect. There's a whole range of critical incidents that may cause that kind of relapse into high levels of psychological distress. Now, there have been, as I mentioned early, many studies have been done documenting the prevalence of distress and also looking at the risk factors for higher distress. So we know quite a bit about this. There's been plenty of descriptive work, although I would have to say that the bulk of the descriptive work has occurred in breast cancer, very large-scale longitudinal studies, and there is less of this in some cancers, including, I would suspect, head and neck cancer and certainly in lung cancer. But we do know, and from the studies that are available, and this will make, I'm sure, sense to you just on a common sense point of view, that if someone has a late stage or an advanced disease, or if they're having very morbid treatments, and of course treatments are often more morbid if the disease is advanced, that is a risk factor for higher distress. And this may trigger for you thinking about your head and neck patients and some who have less severe illness, earlier cancer, their treatment's not as morbid. They do better than those who have very serious treatments. A young age. If people are very young when they're diagnosed with cancer, they tend to have higher levels of psychological distress. They often will cope better physically because they're younger and stronger, but they'll be more distressed. And that makes sense too, because you don't expect to get cancer when you're young. You're also likely still developing your career, forming relationships, perhaps having young children, more financial insecurity in your younger age. And so these things are going to predispose you to higher distress. Not having children seems to be important, and I suspect that relates to how fertility can be compromised by treatments, or having small dependent children because your responsibilities are greater if those children are dependent, and your biggest concern may in fact be about who's going to look after my children if I'm unwell or if I die. Very consistently, socioeconomic and educational disadvantage predicts poorer outcomes for both distress and also for physical well-being and for satisfaction with life. And this as does low health literacy, poorer quality of life in people with low health literacy after cancer, which reflects the resources that you have available to you to cope with a very challenging situation are less if you are at already a socioeconomic and educational disadvantage, or if your health literacy is such, you can't really understand a lot of what is going on, and you're not as used to taking control of your health as you will need to if you're having treatment for cancer that may be prolonged and have prolonged side effect profiles. Very consistently, people who are unpartnered or single will have higher levels of distress. There is limited data on the LGBTQI+ community. They're not easy to access in these types of studies, and they don't tend to, by the very nature of a marginalised to some extent and small group, harder to access for research. But there certainly is data to suggest that their experience of cancer is more difficult. And some of this is related to their sexuality not being supported or considered through the treatment experience. And of course, comorbidities comes up, because if someone already has a series of health problems, again, they're less able to rise to the challenges of the new treatment, and they'll often struggle more than those who, if a person comes to treatment and they're strong and they're healthy and fit, they're going to cope with the rigors of treatment likely better than someone who does not. Now, the point of me going on about these risk factors is to say to you, just to keep them, I always, when I'm working with people with cancer, I keep these in the top of my mind so that when I've reviewed a patient's chart before they come to me, I've already had a good look through that. And I already know if this person has risk factors for higher distress, that I need to be taking particular attention and perhaps do more close follow-up with this person than someone who perhaps does not have those risk factors. Now, I'm going to talk about health-related stigma for a moment, and because I think this is quite relevant to head and neck cancer. And in the early years of cancer, when cancer was, before we had effective treatments, and often a person was diagnosed with cancer and they didn't have access to accessible and effective treatments and had a poorer outcome. Cancer itself in general was stigmatized, but over time that has changed with improvement in treatments and with the very public advocacy movements that, for example, breast cancer patients have developed. They were probably the first group really in the 50s to start doing a version of cancer advocacy from a consumer point of view. And prostate cancer came somewhat after that, probably about 2 decades after that, to change perceptions of what a prostate cancer diagnosis means. Although I will say for head and neck cancer, I don't know if any of you were, I certainly was around when we had the Laryngectomy Association, who were consumer advocates, who are very active in reaching out and supporting other people who'd had head and neck cancer and who'd received a laryngectomy. I worked with those groups back in the 90s. So there was some advocacy action happening then. But I think it's pretty accepted that there are still stigma issues, health-related stigma that arise for some cancers, certainly lung cancer. And I think what my knowledge of the literature is that this is present in head and neck cancer. And I have done work with head and neck cancer patients in the past, and I would say that was my observation as well. Stigma is a social phenomenon. It has individual consequences, but it's a social phenomenon. It's when society labels someone as tainted and less desirable on the basis of some sort of characteristic that marks them out as different. There's been a lot of research, and I've done a lot of research on health-related stigma in lung cancer, which comes from the societal perception that if a person gets lung cancer, well, they self-inflicted that through smoking and their outcome is going to be poor anyway, and it's going to be awful. And this is health-related stigma is a very serious business because, well, first of all, it's not fair. It's not fair to label someone on the basis of a health matter. And this does occur. But also we do know that health-related stigma contributes to psychological distress in patients who have it. And the effect of the stigma, when it is most likely to result in higher psychological distress, is when that stigma is internalized from a social phenomenon to an internal phenomenon where the person feels ashamed or guilty about their cancer. Now, the cancer control movement was really important in reducing the incidence of lung cancer and other cancers that are smoking related, and obviously is implicated in some head and neck cancers. But the types of advertising that we have done and that I've been involved in as well has tended to play on the idea of guilt, you damaging others around you, and that has not been so helpful for people with lung cancer and head and neck cancer as well. So it's an interesting phenomena that we need to think about how we support people with head and neck cancer in the face of all of that. And of course, for head and neck cancer, there may be significant changes in physical appearance and functioning, particularly in swallowing, that contribute to stigma and challenge a person's real sense of identity and self-esteem. And this is very difficult for many people. If you think about how often we socialize when we're eating, you have dinner together as a family, we meet friends and we go out to dinner, and these are the things that get disrupted by problems with swallowing. And some people will say, I feel disgusted when I see myself eat, or I'm worried other people think it's disgusting. So it's a real issue for us to try and address when we're supporting people with head and neck cancer. I was recently visiting with a friend who'd had radiation therapy for head and neck cancer. And I know he talked to me about how his voice was different and he felt uncomfortable and was only just starting to get used to talking in groups again with his changed voice that wasn't as deep and as strong as it used to be. So it's a loss and a matter of grief for many people. I just put this slide up to talk about the context of cancer experience. And that's just to remind us all that when we have a person with cancer in front of us, they have a whole background that we know nothing about. And if we're listening hard to them, we'll find out about this over time. The people who are diagnosed with cancer may be supporting children and grandchildren, caring for aging parents, growing their own children up, under work stress. They may have other physical illness, financial stress. They may lose valued goals because of changes, for example, in infertility or lifestyle or ability to work. There can be divorce or relationship strain. And if a person's been recently divorced or is already under relationship strain, that is as a predisposing factor. Sex and intimacy can be affected. If you've got someone who's older, they may be still working but considering retiring, and then the cancer experience pushes them into early retirement and downsizing, and that has financial consequences. They may be very lonely. And ultimately, what I observe, I guess, is in people I work with, that once they're through treatment in particular, they're starting to wonder about, well, what is the meaning of all this and what was the purpose of my life? And that can be a very hard consideration for someone. And how am I going to live moving forward? What is my focus going to be now that my life has been altered in this way? Now, you might have wondered, what's this business about the sixth vital sign? But in 2005, so this is, 20 years ago, the International Psycho-Oncology Society called out distress as the sixth vital sign in cancer care, to draw attention to the fact that psychological well-being was not routinely being recognised as an important issue for people with cancer, despite all the knowledge that we had by 2005. We'd had psycho-oncology as a discipline for almost 30 years, so one would have thought we would have progressed more. And that call out by IPOS was endorsed by 75 countries around the world through the International Union for Cancer Control. So the idea of paying attention to distress is not a new idea. It's not a wild idea, but it's a issue that remains, even now, all these years later, often ignored. We do know from continuing research that while in some treatment centres there'll be good screening for distress and good assessment, in other centres it might be ad hoc or it might not exist at all. And the extent to which people have access to psychological care services is very varied across sectors and across geographic locations. This has been taken very seriously in the United States. In 2012, it became an accreditation standard to be implemented by 2015. And indeed, I worked with some people in the US who were involved in very large national trials in teaching distress screening and bringing this into implementation, because it was now an accreditation standard. So the very conservative and well-recognised medical groups have been on board with this for some time. In Australia, routine screening for distress for people with cancer is a national cancer control indicator, even though it's not consistently done. So this is a reality for us when we say we're going to deliver good cancer care. Our question is, what are we doing about psychological distress, particularly important in head and neck patients who we know are at greater risk? That's really a repeat of information I've said before, except for the final 2 points, which is that higher early distress is predictive of later ongoing distress. So we want to catch this high distress as early as we can, and then have that as a sign for us in the care plan that we're going to be watching those patients carefully over time. But there is no point screening for distress if you're not going to do something about it. People have to be referred to or delivered appropriate evidence-based psychological care. That's the crucial next step. And indeed, I've certainly had times when I've had health professionals say to me, well, we're not screening for distress because we don't have a service for them, or we don't know, we're not confident that we're going to be able to deal with this distress if we find it. And I would say to you, that's not really a reason not to screen for distress, because there are services available at cancer councils, if you don't have them in your treatment centre, and just recognising distress and being warm and empathic with that person and suggesting, they go to their GP for support or wherever, is really important. We can't just ignore this. So how do we screen for distress? Well, there are lots of ways you can screen for distress. If you're in a busy clinic, the National Comprehensive Cancer Network Distress Thermometer is an ultra-short screening tool. It's a single item, and I'll show you a picture of it soon, where you simply say to the person on a scale from 0 to 10, where 0 is no distress at all and 10 is very high distress, what number would you be? And in the majority of studies, a score of 4 or above has got the best sensitivity and specificity for anxiety and depression. So it's very easy to use. It's freely available. It's been translated in 71 languages, and they're all available on the NCCN website. The cutoff scores do vary by language, country, clinical setting, and sample, but you're pretty safe to use the cutoff of 4. And in many ways, the whole point of distress screening is to simply bring up the conversation with the person about how are they feeling, what is their level of distress, and what are the problems that are driving that distress, incorporating that into the care plan so that we can move forward with a care plan that looks after all aspects of that patient's well-being. Now, this is a survivorship plan, which I'll talk a little bit more about later in the talk, but I put it in there right now just so that you can see the distress thermometer. On this particular version, it's got different colours, and you'll see it gets hotter, so it gets red when it gets to extreme distress. And there is a list, a checklist there, we call it the problem checklist, of different sorts of problems a person might experience. So this has been made so that the clinician can use it. This is freely available, and you can follow up with Tracy to track that down off me after this if you wish. But it's, again, you're educating the patient as well to be aware of their own levels of distress. And you'll see that in the problem checklist, there's things like difficulty with swallowing or speaking, relationship with your spouse or partner, all sorts of things that are in there that might be causing distress. And once we know what the problem is, then we can direct our attention to trying to solve that problem, either ourselves through what we're able to do within our discipline, or by referring someone to an appropriate service. So it's very easy to do. You can do it face-to-face. I use this. You can do it over the telephone. There are other measures about. There are some slightly, I think the Edmonton group has got one that's a few more questions. And myself in my practice, I use when I am able to, when I have a patient coming to see me face-to-face, or I can test them before I see them. I test for depression using the Patient Health Questionnaire 9, which is a 9-item, freely accessible scale, very easy to score. It has a suicidal ideation item on it, which I'd always like to check for that. And then the GAD-7, Generalized Anxiety Disorder Scale, 7 items, very easy to use, very easy to score. I routinely use those in my practice. That's what they use at Memorial Sloan Kettering in New York City. And I add on to that the Godden Leisure Time measure, which is very small, and that's for measuring extent of physical activity. Because when I am seeing a patient, I'm trying to look at the whole patient, which includes, are they exercising, what's their side effect profile, all of those things, and trying to bring my skills in care to help ameliorate those problems. You can see this has got a whole lot of other places for entering information. And that's because my wellbeing plan is actually a survivorship care plan that was developed in a research group that I'm involved in. Now, I'm going to talk to you about the framework of care, the low intensity model. And when I first started working in psychological care with people with cancer, and this was sort of when psycho-oncology was really just getting going, we really didn't have a good framework to put all the pieces of our care in so that we could guide us and we could know that we were taking an evidence-based approach. The low intensity approach is cognitive behavioral in its orientation, and it draws from, it's evidence-based. It draws from 3 perspectives: the stress and coping framework that I really talked about very briefly before, and I'll explain this a little more in a moment. A problem-solving approach, which I think many of us as clinicians really relate to, and the idea of psychological flexibility, which is about assisting a person to get less fused with their distressing thoughts, be able to look at their situation with different perspectives and react to their situation in a more flexible and less rigid way. The linking element from these three perspectives, they're all cognitive behavioral, but they focus on a different aspect of that. Cognitive meaning thoughts, and behavior meaning what are you actually doing? What actions are you taking? But they're very focused on realizing that how a person thinks about their cancer and the situation in which they're in and the way they respond to that thinking. Do they get tied up and stuck in it, or are they able to balance that thinking out? These things all influence the behaviors that they do and ultimately their psychological outcome. What's nice about that as a model is that it gives you ideas for what you can intervene in. Now, low-intensity psychological care doesn't mean we don't do much. It means that we titrate what we do to the needs of the patient. So we match the intensity and the focus of the care to the level of need and the nature of the need. It is completely person-centered, where the context and values of the individual guides the intervention. So we're working out what does this person need and delivering that rather than, well, what's in my menu of things and I'll just give you those. We say we're person-centered, but we're often system-centered, and often there's not a lot we can do about this. But for psychological care, we need to be person-centered. It's evidence-informed. If we're going to ask people to take on certain psychological strategies, we want to know that there's good evidence that this will help them. And it needs to connect to self-help that's client-paced, so that we're helping the patient, but we're giving them information and skills and coaching that they can take into their lives after they're out of our orbit and help themselves. Linking to community resources is essential because, again, that's part of they get out of our reach, they go into a community who is there to help them. So low intensity care, therefore, is stepped. It steps up from what we call universal care. And we first developed this model and published it in 2006. So a really long time ago when I was working at the Cancer Council. And at that time, we published that in Oncology, and it was a 5-level model. Since that time, we've really adapted it in practice to be a 4-level model, which I certainly have found practically more functional. So every patient should get universal care, which is patient education, emotional support, practical assistance, access to peer support. We want them doing physical activity and exercise as much as possible, and we need to screen for distress and refer them on if they need more. And what does more look like? Well, more is low intensity care. So that's just a step up. So we've given them universal care. If they're still distressed, we step up to low intensity care, and we deliver the cognitive behavioral intervention that I'm talking about with regards to the stress and coping framework, problem solving, and psychological flexibility. This can be interwoven with stress management strategies, coping skills training, which is really the problem solving approach, psychoeducation, so people understand why they're feeling this way and what the strategies are they can do to help themselves, and decision support where that is required. Moderate to severe distress will require specialised care, so specialised therapy for depression, anxiety, or relationship distress. And there you want someone who does that for a living. So that might be a clinical psychologist, a social worker, psychotherapist, a different, that's kind of specialisation in psychotherapy or psychological intervention. And then acute care, if you've got someone who has got pretty complex psychological problems, and is in severe distress, they likely will need a multidisciplinary team to help them along. So the point of having that framework in your head is when you're assessing someone and you've been tracking them through, is to help you decide, is it my job? Is it someone else's job? What's an appropriate service for this person? So the stress response, Lazarus and Folkman first developed this, focuses on the interplay between the way we think about our situation, the physical reactions that elicits from that, how we label those feelings, and then the actions we take. So to try and put that into practical terms, if someone is thinking about their cancer in a highly negative and rigid way, this cancer is going to kill me, the treatments are going to be useless, I'm terrified of I don't know what's going to happen, those thoughts will drive a fight or flight reaction, which is the blood pressure goes up, the heart rate goes up, the pupils dilate, the mouth gets dry, the palm gets sweaty, a whole range of things. The gut stops working. People can hyperventilate. They're not even realizing they're doing it. They just start breathing in a really shallow way and start to get breathless. And of course, the extreme reaction of that is a panic attack. So it's important to know that the way a person thinks can elicit this. And then for patients I'm working with, if they're having a lot of these physical reactions, we will do work on trying to figure out what's triggering that, what's the thought pattern that's doing that, how could we shift that? If you're feeling that way, you're obviously going to be feeling really anxious. That's how you're going to label that. And then sometimes what happens is the person has that reaction and then they go, oh, I'm anxious, things must be bad. And they get into a real cycle that can be hard to stop. Actions are about the behaviors a person takes. So if someone's engaging in a problem-solving approach to their situation, they're going to be able to manage this better than someone who's avoidant of it, can't bear to talk about it, can't bear to think about it, and is just basically in that running for cover mode of coping. So what we're trying to encourage is balanced and flexible thinking. Of course, people are still going to be distressed, but balanced and flexible thinking as much as possible and a problem-solving approach to the situation. So problem solving is done in this way is also seen as a cognitive behavioral response. People can get really overwhelmed with all the problems they're facing, and just to sit with someone and go, let's work out what are the things that are worrying you, what's the priority problem, how do we want that to change, and what are the possible approaches that we could take to change that problem. So really working through alternative actions, the pros and cons, the possible outcomes for each strategy, defining a solution, and then supporting that person to implement that solution and self-monitor and adapt as needed. And I would imagine that you all use problem-solving approaches a lot with your head and neck patients, particularly with managing side effects and swallowing problems. And this would be something I'm sure you're doing across all your disciplines. Psychological flexibility comes out of the acceptance and commitment therapy wave of cognitive behavioral therapy. And it's the idea is, as I said earlier, it's about being able to take on different perspectives to the problem, think flexibly about that, and not get really bogged down and tied up with unhelpful thinking. So I find that really helpful when someone has got in a situation that's really tough and we can't fix it, but we need to help them manage better. And I find patients take to that really well. So how can, this is now, I apologize, sounds like a big plug for me, but the reason why I'm talking to you is because I did some training with Tracy into a guide that Jeff Dunn and myself have written that's available through Australian Academic Press, where we've taken these approaches and we've developed modules that go across all cancers that will talk you through how you can deliver this type of support. And for some of you who are already doing this, these can be extra resources. It has patient handouts that comes with it and worksheets to help people do self-reflection and work on this when they're not in the room with you. So it's available, as I said, through Australian Academic Press, and it's also comes with an e-library so that you can download these sheets. It's really a toolkit to help people who would like to deliver psychological care that derives from these perspectives. There are two foundation components to the intervention. Foundation 1 is about distress screening, and I've discussed that with you already. And Foundation 2 is about agenda and goal setting, making sure that you and your patient know what the priorities are, what you're trying to achieve, and then from that you can pull out the flexible components that are relevant to be included in the care that you're delivering. There's a stack of flexible components. And you'll see some of this reflects what I've been talking about. General psychoeducation, that says coping with the prostate cancer, but there is a generic one that's from other work I've done. Stress management, making decisions, managing relationships, problem solving, managing difficult thoughts, pivoting to valued directions, which is about helping people kind of move to what's my new meaning and purpose. The masculinity and prostate cancer one in the generic manual is now about values and identity. And it also talks about managing stigma with people, sexual function and survivorship care. So it's pretty comprehensive, and it reflects, I've been working with people with cancer for goodness me, 30 or 40 years. And so what I've done with Jeff is we've identified what are the most common problems that we have people coming over the years across all cancers talking to us about, and how have we found ways to develop that, to deliver care that targets those issues. So it's a toolbox approach. The idea is you're already there at the bedside, you're delivering care. Some of these tools may well work for you, and you can easily apply them again within your scope of practice. Just very quickly, because we're kind of running out of time, we've also developed a cancer survivorship essentials framework. It has that, and this was done through a very detailed research project that I don't have time to really describe. At the center of this is that we're trying to promote the personal agency of the patient. We're making sure we use evidence-based survivorship interventions. Health promotion and advocacy is part of this. Shared management between the patient and the healthcare team. Good coordination of care so that people get the right support at the right time and delivered in the right way for them. And vigilance about not just illness problems, physical illness problems or cancer recurrence, but also vigilance about psychological and social well-being. So those principles have been used to develop the wellbeing plan, which is a survivorship care plan. It allows you to put in, it's a fillable PDF. This is freely available. You can fill in the details about the patient so they've got a record of everything. You distress screen them. You work with the patient over here on what their wellbeing priorities are, what they're going to do, what you're going to do, who they're going to see, what the GP needs to know, and what referral services you're going to be, and then what other services are available. The wellbeing guide that's in there goes through these different components of the model, and we've written for each of those. We're explaining what this is in lay language, and then what can I do? So we make some suggestions to patients about what they can do to help themselves. This is a great way of them recording what's happening, sharing that with their GP and keeping track of their care, because you will all know that cancer care can be very complicated and hard to track. So just in closing, some brief practice tips for you. And I developed these when I was doing some work with GPs who just like, give it to me fast, Suzanne, I want some quick tips. So brief distress screening is just really important. It gives you direction about whether you need to do more in-depth screening for depression and anxiety and suicidal ideation. So it is a quick step that helps you know whether you then need to do more. If people have got low to moderate distress, just normalizing the experience through psychoeducation, teaching them some self-management, stress skills, that may be as much as you need, giving them materials so they can continue their learning, and re-screening them later to see how they've gone, or making sure they know where they can go if things don't go so well. It's really important to attend to the salient problem, not what you think is the problem, but what the person thinks is the problem. And bear in mind that this can change over time. Close to diagnosis, fear of dying might be the main thing. And then after treatment, it might be side effects. And then later on, fear of cancer recurrence when a person is out of the health system to some extent, that may emerge, or coming to terms with the changed self as life goes on, but life is different. Always remember that life course and culture influences how people express distress. So we've always got to, I like to say, come to our patient like we're a naive explorer, and they're the interesting land that we're going to learn about, and being curious and compassionate about what is worrying them and how they think we can address that. Partners and family are crucial in support. just very briefly, I'm not an exercise physiologist, but I'm a huge fan of them. And there is just great evidence that personally tailored exercise that includes both aerobic and resistance training improves mood, can improve sexual function, improves quality of life, can reverse some of the effects of treatment, particularly when sarcopenia occurs or bone loss. And there is even in vivo evidence now that proper exercise, tailored exercise, actually has a cancer suppressing effect, systemic anti-inflammation effect as well. So people with cancer who exercise live longer than people with cancer who don't. There are many reasons why getting your patients into a good exercise program is important. And that's why when I screen for psychological distress, I screen for physical activity at the same time. And then remembering about the important role of the GP and care coordination in organising a better access to mental health care plan for people who require psychological intervention, and making sure that people know about the chronic disease management plan if they need allied health support. All those things where we can let our patients know there is help available and this is how you get it. So I'm going to stop sharing, and I can't see a question in the chat, but I might hand over to Tracy, who's joined us, and see if she has got something she would like to add.
Thank you, Suzanne. I hope everyone can hear me. Can you hear me?
I can hear you.
Perfect. So hopefully, firstly, thank you so much. That was amazing. And I'd like to apologise for not being here to give you the introduction that you so well deserve. I'm sorry, but the internet didn't want to like me tonight, so I apologise for that. There are no questions in the chat box, and what I might do is just kind of talk about my experience. And I was very, just so people can, if they've got any questions, please start typing away. But I was very fortunate to do an online course with Suzanne, I think it was late last year. And it's quite amazing. I think as healthcare professionals, we probably do a lot of that screening in our consults, and we kind of don't realise and take it for granted. I find, especially with the distress thermometer, I can virtually ask those questions without sitting there and saying, can you tick that? And it kind of alerts all sorts of different responses and conditions that the patient might be going through. But I think in my experience too, I think it is that initial phase of that early diagnosis that the patients really need kind of a lot of attention and support and information. And I really believe if they get the correct information at the correct time, that it really makes their journey so much more tolerable for them, and probably not as distressful as they go through. And I'm not making any light of what that cancer journey is, but I think, you know, as healthcare professionals, just being able to arm them with the correct information that they need to know. And often, you know, halfway through treatment, and if you touch base with them and say, you're exactly, I know it's really awful, but you're exactly where you should be at this stage of your treatment. And often just that reassurance that, yes, it's tough, it's toxic, but where you are at the current time is kind of where you should be, and we keep on going. I think that's very helpful in a cancer journey as well, just so that they can be accessible to you, or that information, or point them in a direction such as the Cancer Council, or you know, different cancer sites, websites, just so they can access that information.
Really good points. And Tracy, I agree with you. When people realize that, okay, I am meant, this is what it is, and I'm not worse than anybody else or better than anybody else, they can kind of take a breath and go, okay, I'm moving through the experience. So I think that's a really great insight that you've shared with us.
One more point that I tend to use, that if I feel that my patients are at that point of being quite distressed, and often I will ask them if they would like to speak to someone that's been through exactly what they've been through. And you'll get people that will be very open to that and others that won't. But I really think, you know, just seeing someone that's been through what they are going through and on the other side. I'm really fortunate to run a support group for head and neck cancer patients. And at that meeting, it's so humbling. I have patients that are 19 years out, and then some that are only kind of 6 months out. And it's the most amazing thing to see them all share and talk and support each other. It's a really good thing to be part of. So never underestimate, you know, your patients that have been through this journey, that, you know, and I'll often say to them, you know, if I have a patient that might need to have a conversation with you about what you've been through, would you be open to that? So I've kind of got this list in my head that I can use those patients as well. And I find that really useful and supportive as well.
Well done. Good on you.
Well, Susan, I think you've filled everyone with lots of thoughts. We still don't have any questions in our question and answer box. So without further ado, I'd like to thank you so much for giving up some time in your very, very busy schedule. Thank all the participants for joining in tonight. And any information about any of those out of the toolbox, I'm sure we can share through the ANZ as well.
Absolutely.
So thank you so much.
You're welcome. Thank you. Thanks for inviting me. I appreciate it.
Talk soon. Thanks,
Okay.
everyone. Good night.
Bye.